if you're a dermatologist and you take a photograph of your phone, you're not, got an accurate representation of their skin. You're not capturing fine lines and details. So you're losing treatment options of what that patient might get from your practice. And that becomes a feedback loop, a financial one too.
Hello and welcome to The Crow's Nest, the official podcast of Candice Crow Design. I'm TK, and today our guest is Woodrow Wilson, the CEO and founder of Clinical Imaging, an Australian-based company that's really taking the guesswork out of capturing high-quality, consistent before and after photos. The conversation today dives deep into not only how the clinical imaging system works, but also how practices can improve the quality of their before and afters, even if they're not using a system like clinical imaging. We hope you enjoy listening as much as we enjoyed the conversation. Woodrow, welcome to the Crow's Nest. Let's start with you telling us a little bit about yourself and why you think before and afters matter so much.
Thank you very much for having me. It's always nice to connect with people who are fighting the same battle, albeit on the other side of the planet. So I'm in Melbourne, Australia, and I've been a commercial photographer since 2007. And I'll never forget 2012, I saw my first plastic surgery congress in a little town called Darwin in Northern Australia. And I was just a conference photographer at the time. And I remember taking photographs of the professor who was on the plenary talking and the hallway, and all these people were really fascinated with what this surgeon was saying. But the contrast was the words that were coming out of this surgeon's mouth were really scientific, umbilicus this, abdominoplasty that. I didn't know what any of that meant at the time. And then I saw the projector behind him, and he looked at his evidence, his photography of what he was talking about, and it was shocking. And I was looking around this room, and I'm like, yeah, surely, all these smart people then they can see that this photograph isn't correct or isn't objective or isn't scientific. And then, I did a bit of digging. And I'm like, oh, this is how the standard is everywhere. It's very rare for someone to have scientific objective imaging. And yeah, that was my start. And yeah, we are 2025 soon. I started a little business back then. We've got 140-ish clients running a system we designed in 9 different countries across a lot of different specialties. And I'm very proud of what we've done to try change this industry and try move it forward for everyone's benefit. So for patients, for science, for doctors, and yeah, that's my little brief history.
Well, that's wonderful to hear. Most of our listeners are going to be plastic surgeons, dermatologists, med spa owners, um, nurses, or office managers or marketing people in the aesthetic field here in the United States or
Yeah.
Canada. And so we are excited to have you on the podcast. At least every week we get asked, do you know of a great photo taking system? And I didn't know about you for the longest time. And I think just in the matter of the last couple years, we found out more about you. And then when we were in Vancouver, can't remember who was it, said, oh, yeah, let me help make an introduction. And then there it was. So your system looks so spectacular, so modern. Um, you want to talk a little bit about it and how you
Yeah,
approach
sure.
helping a practice?
Well, I think the point of difference is that we realize very quickly that no one's really interested in the technical side of photography. They really just need a solution that is easy to use, reproducible, and is a really short learning curve. Because often what happens is people get sold equipment that they don't know how to use. There's high staff turnover in this industry, and then suddenly you've got a very expensive lemon sitting there in the corner that someone has paid for as a solution, and then no one knows how to use it, and then you're back to square one. So what we designed way back then and has evolved continually since is taking off the shelf parts, so cameras, lighting, and software, and amalgamated in such a way that it resembles what a commercial photographer would use in what we call e-commerce, where you are doing a tethered workflow where you connect a camera to a computer, and that allows you to see what you are shooting in real time on a big screen for the patient to consultate for the patient to have a consultation with. And modern SLR cameras have come a long way in the last 10 years. So most of the time, people are using a camera that resembles a phone. It's just a little bit bigger and it's got a nice, grip and a lens attached to it, but it's point and click, which I think has been the biggest point of difference for us over the last few years. People, they love the results, but they don't know how they get there because all the systems are pre-calibrated. So it's point and click, and it's mainly about patient experience and that clinician or that administration staff following some framing guidelines, which are really easy to do.
That's excellent. Do you have TK? Do you want to take the next one?
Yeah, I really liked what you said there about making the process repeatable. And just some of the other things that you touched on with the turnover of staff, and then having the limit in the corner, and then there the doctors often don't realize the cost associated with not having a good process to get good photography. There's more than just kind of not being able to show the results on your website. What other costs do you see when
Yeah.
practices don't have good photographic standards?
Look, it costs them from the first day they open a private practice all the way to their last, in my opinion, because primarily, if we go backwards from the marketing aspect of a clinical photograph, primarily it is a medical record. It has to be done. Jurisdictions change in terms of their legalities. Australia were quite strict here in the sense that clinical photograph is part of their medical record. It has to be taken as part of their medical journey. So that's the first thing. Second thing is patients don't know what they don't know. And you need to use standardized, high quality imagery to be able to do a thorough consultation with them about the shape of their face, about the shape of their body, if you're a dermatologist, you're interested in their skin, their texture, their tone, their fine lines. If you're an injector, you want to be able to show their dynamic movements in their face, how they animate. All that is predicated on being able to do it with a scientific, objective photograph that is higher quality than what they would do on their phone. So if you are not giving that patient the best information possible from the first interaction, when you meet them face to face, or they see your marketing, or your communications on your website or your socials or your education platforms, you're doing yourself a disservice because they don't know all the amazing things that you've studied years to do. They're looking at some terrible before and after that's a stock photograph. That doesn't speak to the specialty or just how much knowledge there is in these clinicians who have studied years to do this work. And it drives me crazy when I see it because, I've flipped it around now, the formula. I've got first year injectors who have better photographs than medical journals. And I'm proud of that. But in a way, it shouldn't be like that. It should be like those medical journals, those plastic surgeons who have been around for 30, 40 years, who are the ones who are on the training circuit for all these big companies. A lot of the time, their photographs is really substandard. And we look at histology, we look at ultrasound, we look at dermatoscopes with objective science, but then 2D photography seems to be this big gulf where no one really does it properly. So I think it costs a lot of different things, but by the end of the day, it shouldn't cost anyone anything. It should be the biggest opportunity people have in their practice.
Yeah, one of the things we deal with on the marketing side of the before and afters, and one of the things I tell prospective clients of our Bragbook software is that, the before and afters are the visual representation of your life's work. And
Right.
you're really not doing yourself your life's work, all the years that you spent in school, if you don't take good before and after photos. So, and if you get the a quality before and after photo when you're going to publish it on all your social channels or wherever, you don't have to spend as much time cropping and editing it. It's already kind of prepped and ready for you. So there is a tremendous cost to not taking good before and after photos.
Yeah, and I think if you zoom out a bit too, this industry has been under a lot of pressure the last 5 years, especially with all the studies that have come out around body dysmorphia and unrealistic expectations. And photography is key to that. And I look at the way ethical practices will have really high quality standardized imagery to be able to give patients realistic expectations on what their breasts will look like afterwards, what they can expect with 1 mil filler, or what they can expect with a melasma treatment over 3 months with a laser. And that gives a more informed patient that trusts that clinician, who returns to that clinic, who doesn't just shop around because they're treated like cattle. This industry has grown so much over the last 15 years, and it will continue to grow. But with that needs to come standards, and photography is one of the aspects that needs to be standardized more and more. In Australia and New Zealand, they've started that. The government, has really clamped down on how we market, how we represent photographs in this industry, which is a great start. And hopefully we'll see that, seed to other markets too.
Do you see that kind of the US following that, increased standardization of marketing and, that, I mean, you really did in Australia and New Zealand clamp down on marketing and, I do think in the long run, it really does increase the industry reputation. But do you see
Correct.
Americans ever, ever embracing that?
Um, I'm not sure of any regulatory things at the moment. I know that in California, they're pushing through some AI regulation, which is another thing to talk about in clinical photos.
Yeah.
To be able to label an image as manipulated or generated by AI, because they've already started to see AI before and afters out there. But we've gone for the AI regulation as opposed to the photography regulation. If you're in Europe, for instance, if an image has been manipulated, it says so in the bottom right-hand corner or bottom left-hand corner. There's a little caption there. And the EU mandated that bill to give the public a realistic expectation of what they are seeing is real or not. Whereas clinical photographs have sort of gotten through that for many years, but where they're not regulated. So I do hope that the societies do look at it. At the moment, I'm working on a paper about standards for the public to be able to discern if an image is real or not, on certain variables like exposure and authenticity and color and detail. And my hope is that that paper gets pushed out into the wider world, and then different societies and congresses adopt that to say, well, this is our rating system, so that when you have a surgeon who comes up on plenary and their images are labeled an F, we understand why it's an F and why it's not an A. And it's been a bugbear of mine for many years, but specialists should respect one another, and the educational content of their lectures needs to be, they get up there and they say, look, we've got some disclosures. We work for these companies, blah, blah, blah. And there should be something about my images have been rated an A because my practice takes objective imaging very seriously for, realistic expectations and educational content. So I'm diverging, but my point is
That's okay. It's good.
Yeah, we have to as an industry push this forward. I'm obviously an industry partner, so I sell into the industry, but we have to push these standards forward to a point where the government will take notice. So that's what's happened in Australia. It took many years, but I'm not sure about the US at the moment. I would hope so.
Absolutely.
I know we've just talked about the cost of poor photography, but what is the biggest difference that you see between a well-captured photo and one that's not up to standard?
Okay, so do you mean like in a technical point of view?
Yeah, yeah.
Okay. So to answer that, there's the optics of a professional, and there's the optics of the public. The idea is that we My opinion as a professional is what informs the systems that go into a clinic. But the most important point of view is often the public. So when we install, we sort of train our clients on a bit of media literacy. Like, how do we know that an image is real? These two colors are not alike, or the shape of this face is distorted. So there are certain things that I wrote in a paper with a plastic surgeon, Dr. Peter Callanier, in Australia a few years ago. Simple things like, is the image an accurate representation of someone's face? And by that, I mean, has the face been either barrel distorted, so stretched, or pin cushion distorted, where it's compressed? And I see it all the time with facelifts and injectables, where the clinician will pick up a phone, take the photograph, and they'll take it at different distances. And, photography is basically imaging physics. If you are too close to a subject, it has a distortion effect. If you're too far away, it has a distortion effect. So there's a middle ground. And that's measured when we do our installs, and we know that the clinician has to stand on that particular point in order to get an accurate representation of the face or body. So distortion's a big one. Color is the next one. Often when people don't have a system, they are relying on ambient light, so the overhead lights, the time of day, in order to illuminate their patient. And the angle and shape and color of light has a massive variability in time of day, and a massive inconsistency with overhead lights. The way we photograph in my system is that we reproduce what the sun is made our brains to evolve color to be. So we talk about something called Kelvin, which is, the sun is 5,500 degrees Kelvin, which is white light. The sun's not yellow when you look at it. It's actually the atmosphere that gives it that hue. If you were out in space and you looked at the sun, it would be bright white. And our brains evolve color for that. So when we're under incandescent light or fluorescent light, our brains will shift color to make it look realistic. But that's not what a camera sees. And what's cool is cameras are basically computers you can program. And when you program a camera for white light, so 5,500 degrees Kelvin, which comes out of your light source, which is typically a studio strobe, a flashlight, then every time that photograph is taken of the patient, the skin tone is exactly the same, and it's the right skin tone to their Fitzpatrick. So if you have someone under incandescent light, their skin will shift yellow. If you have someone under fluorescent light, their skin will shift blue-green. If you photograph someone side lit at 8 o'clock in the morning in your office, and then someone side lit at 4 o'clock in the afternoon in your office, the shape of the face is completely different. So you can't be sitting there talking about the shape of this person's rhinoplasty is so great and all that superfluous, fluffy language that some marketers use. But then you're looking with your own two eyes at this image, and they're completely different. The variables which we are judging this clinician or the surgeon on, which is shape of the nose or contour of the jawline or projection of the lip, they're completely different. So you might as well have no image there, because it's really belittling the skill of whoever did the work. We always take these photographs as a safety net. Cosmetic work has become a retail experience, has become normalized, and that's fine. But what shouldn't be normalized is the assumption that everything's going to go okay every time, that you're not going to have a patient who has underlying body dysmorphia or a disagreement with you on the result or the treatment outcome. And photography is there as your safety net. You don't want to be fiddling with your phone with a patient who's just paid tens of thousands of dollars, complaining about, their smile is different, the shape of their body is different, and you told me it was going to be this and it's become that. And then you're sitting there fumbling on your phone, scrolling back 6 months, trying to find their photographs on your personal device. The idea is that safety net is to show the patient, one, all the other cases you've done, what can happen, what the risks are involved in undertaking the procedure. And when things do go wrong, this is how we take care of it. And you build that trust with the patient. And all of that is a visual exchange, because you are obviously telling them something, but you need to be able to show them, this is what your lollipop scar is going to look like. In your skin type, you might scar this way, as have 6 other patients that I can show you in different case studies. And you need that information to be readily accessible because everyone's trying to squeeze in little, as many patients into tiny consultation windows. You need that accessible to you in a safe sort of way. So I think the last aspect of good and bad photographs is data management, which really is time management. And when you have a system that organizes your files into patient files, into patient named files, that is stored on the cloud, it's secure, it has two-factor authentication. So those who are allowed to see these photographs can see them very quickly and easily, and those who can't see them or not allowed to have no chance of getting access. So you need that as a fluid data stream. So when you are doing your consultations, or you've got 4 injectors and 2 surgeons and a couple of dermatologists in your practice, that everyone has a data flow of being able to access their photographs for review, consultation, and eventually for marketing. So when people take photos on their phone, they think, oh, this is a quick process. I'm just going to take it. It's done. See, I don't need anything else. But they're exchanging time now for time in the future because that file isn't organized. There's no name. There's no data security. If it's on your personal device and you lose it on the way home and you've got to remotely wipe that photograph, you might lose, 6 months worth of cases. That's not the sort of professionalism that a clinician should bring to their photography at all.
Oh,
I
yeah.
love that. I jotted down exchanging time now for time in the future.
Well, yeah, and one of the things that you touched on with the distortion based on the barreling, I mean, it seems like that should just be, because patients will get home and they'll take a selfie and they'll be like, oh, my face looks different now than it did when I got the photo at the office, and so just having that kind of proof of what the actual result was, framed properly, just seems so invaluable to being able to protect yourself, but then also to, give realistic expectations to patients in the future.
Yep.
And I'd maybe add this to it as well, that a modern, sure, you have a stream of patients in their early 20s who are just looking for lip filler. They're going to find cheap lip filler and they're going to get lip filler. Someone in their mid 30s or 40 like I am, or in their older, they come into a practice and they are relying on to trust the specialist who they are paying a lot of money to tell them what is going on with their anatomy. So how's my skin texture? How's my volume loss? How's my sun damage? How's my symmetry? Those sort of things are all visual things that need to be documented and then shown to the patient. If you're a dermatologist and you take a photograph of your phone, you're not got an accurate representation of their skin. You're not capturing fine lines and details. So you're losing treatment options of what that patient might get from your practice. And that becomes a feedback loop, a financial one too, because you are, not showing them the full, if you've got a $300,000 laser in the back, you want to be able to use it. If someone comes in and you aren't able to demonstrate to them with good imagery, some filters for showing like epidermal melanin or capillary damage, you're losing a completely lucrative treatment pathway. And we talk a lot about pollination in clinics where someone comes in for what they think they need and then they leave with what they should get or what they're advised to get. And often that conversion is done through really high quality photographs, things that they wouldn't see on their phone, they wouldn't see in the mirror, and their friends would probably not notice. And it's confronting for a patient because they're like, oh, my skin's actually really dry. I've got, undiagnosed rosacea, or I've these eye bags that I'm worried about. No, I don't need fillers for it. It might need a facelift in 3 years, so come back. Those sort of conversations don't happen if you're just using your phone. And then
Right,
they might, but then it takes a lot of convincing. Or you might give them a mirror and then they look at the mirror, they nod and acknowledge, and then they forget what they saw. And there's no record of what the mirror saw either. So
So,
yeah, I just thought I'd add
yeah,
that in.
absolutely. So the one thing I read a quote from you was, as
Cool
with any
quote.
scientific endeavor, it's all about reducing the number of variables in taking before and after photographs. The only thing that should change is the patient. And I thought
Mm,
that really was, it really struck me because as I was preparing for this, I was watching other types of photo taking systems, and they were holding the iPad up and kind of moving it, trying to match that ghost up, and
Mm,
then they have to flip the finger over while it's kind of being matched up, and click at it right just the right second to match
yeah,
it up. So that variable of just trying to stand, I know
yeah.
I'm not a true photographer, but I'm an artist. My sister's a photographer. You use a tripod if you don't
Mm.
want something to move, and
I'm actually going to disagree with you there on the tripod, and I'll tell you why.
okay. All right. Okay, good.
Um,
Go right
so
ahead.
um, tripods sound like a good idea. And why do
Okay.
why do people think they need tripods? One, to get a stable image, like a sharp photograph, where the
Yeah.
camera doesn't shake or move, and two, to get a reproducible angle. So how we did it differently is use a little bit of science. Those studio strobes that we attach to the ceilings to use as diffusion and illumination of the patient, those studio strobes send out a pulse of light.
Hmm.
And that pulse of light, the first 800 milliseconds of that pulse of light coming out of that strobe, bounces around the room and completely freezes whatever the camera is focused on. So that person could be shaking, you could be shaking, and it wouldn't matter because 800 milliseconds is really fast.
It's fast. Yeah.
So you can get faster, but that's the consumer grade flashes that we install, and that means that when you focus and you take a shot, it's sharp. So you don't need the tripod. So that
Okay.
gets rid of a big apparatus that is intimidating for people.
Yeah.
Secondly, I was finding when I did my first few case studies is that everyone would use the tripod in the last spot that the tripod was used, as opposed to looking at what anatomy they were meant to be photographing.
Oh boy.
And there's some really handy anatomical planes you can use. So most cameras and the ones we install have electronic spirit levels. So
Hmm.
when you hold the camera in a vertical position, I'll just grab one. When you hold the camera, pretend like you're the subject. When you hold the camera vertically, there is a spirit level in the back of the camera, which lets you know that the camera is parallel to the ground. So that's the first variable. We want to be parallel to the ground. Second variable is our distance and our height to the subject. And that can be solved by using the spirit level in the back of the camera. And if we're photographing the face, we overlap it with the Frankfurt plane, which goes from the tragus through the bottom of the infraorbital ridge to the tip of the nose. You overlay
Yeah.
those two things, you solve all the problems in terms of your distance, your height, and your angle just by doing those things. So
Wow.
before the clinician picks up the camera, we say, well, what are we photographing? The face. What's important? We want the skull parallel to the ground. We want the camera parallel to the ground. How do we do that? Align those two lines, done. And because your cameras have such high resolution, if there is, a 10% variability either way, when it comes to post-production, which is really just cropping, you've got so much room to maneuver and to crop in because there's no detail loss on a 24 megapixel camera
Wow.
if you're zooming in. So that solves all those problems. So then you don't need tripods, you don't need C-stands or floor stands, you don't need umbrellas, you don't need soft boxes. And the visuals on our website of the installations show this, but it makes the photography area so much less intimidating for users because they're not walking into what looks like a professional film set. They're just
Yeah.
picking up a camera that's attached to a computer.
Wow.
And because the flashes are ceiling mounted, no one needs to worry about it. They just take the photo and then this big pulse of light goes in the room. I think the way we do lighting and then it's in the paper, it was completely novel, hadn't been done before. And the status quo of a lot of medical journals was to have a 3-point lighting system. And we totally turned that on its head for better.
Wow, that's awesome. So you don't
Mm.
even need like a ghosted overlay.
No, because you're doing the same whether you're photographing a rhinoplasty
Yeah.
or lips for you're doing the same process each time. You're aligning the Frankfurt plane,
Yeah,
and you're
exactly.
capturing this image plane, and then you zoom into the indication. 24 megapixels is a lot of resolution if you're talking about a raw file with a large sensor. the misnomer is that people look at a camera like, oh, my camera is 50 megapixels. But what matters is not the megapixels, it's the size of the sensor in the camera. Bigger sensor has a larger, what we call photosites on that sensor, and they collect more light, more color information, higher fidelity information. And the other danger of a iPhone, Samsung, Oppo, whoever you use, is there is a really biased interpretation of skin tone, of skin detail in those images that comes through the software pipeline of how they manage photos. So you would probably notice when you take a photograph with an iPhone, everyone kind of looks a little bit better than they do in real life. And that's because they're trying to even out the skin tones or the exposure versus a really bright background. And the photos all look amazing, but it's not reality. And we want to be dealing
Wow.
with reality in a clinical setting.
That is super important.
All right. So in the US, we do have some camera photo taking systems on the market. Some probably
Mhm.
okay, some probably could use some work.
Yep.
Maybe you could talk to us about some of the difference between, I'm sure you're familiar with some of these TouchMD Snap, PhotoRx, and Canfield's systems and how they compare to clinical imaging.
Mm. Look, I think the I would predicate it by saying I'm happy there are solutions out there, and um, having something rather than nothing is important. I would say I have, as a technician, there are some things that I can suggest from the other products in the market which I have issues with or can see problems with. So we start with TouchMD Snap. I know they've got some really good ghosting tools, but from a technical point of view, they are still photographing on a phone or an iPad, which, despite all the marketing you'd get from Apple or Samsung, there are still light years behind what a mirrorless or an SLR camera can perform. And it's not a case of just having equipment envy a camera versus a phone. It's science. It is what that device is able to capture. So the detail we are interested in terms of skin tones, fine lines, texture, the reproducibility of that photograph from a camera is always going to be better than a phone or an iPad, because a camera you can program, say, okay, I got a user setting for this environment with this lighting, and it's always going to capture those settings. With a phone or an iPad, you are essentially on automatic. So the
Mm.
time of day will matter, the light source around you will matter. Um, RX Photo, again, I think it's a phone-based system, so the same things apply. Um, the the big player in the market is Canfield in Telestudio, I think.
Yeah.
They're in Telestudio 2 now. Look, it's an impressive piece of equipment. I would say the major problem I have with it is lighting. So the light source on an Telestudio is attached to the device itself. So it's mounted on the bracket, and then you've got the patient that stands in front of it. The issue I have, and can you see my hands still?
Yeah.
Yeah. The issue I have, and I've had since I first saw their first generation one, is the lighting angle. So if you've got a patient and the IntelliStudio, that light source is perpendicular. So the light leaves the IntelliStudio and hits the patient. When you have a light source that's perpendicular to an object, you are filling that object's crevices, all the topography of that face. So you flatten the image. What we do is have ceiling mounted light that comes down at a 45-degree angle. Why this is important is because we want to create three-dimensionality to a face or to a body. And you can only do that when you've got angled light. If you have front-facing light, and we used to use this in fashion photography when a model would come with bad skin, you would fill the subject to be able to hide all the fine lines and wrinkles that they would have in their skin, or the acne they may be experiencing. So what we've shown in some studies is that when the light angle is sort of 45 degrees, 2 o'clock on a cloudy day, comes from the ceiling onto the patient, you get that nice depth, you get some functional shadows that's creating a three-dimensional angle to the face or to the body without inflicting or creating some false shadows, which sometimes people can do when they have 2.45-degree lighting, when they have two big light sources close to the face. The biggest example of that is when people do they have their light sources. They have one light source here, one light source here, and one on the background. Background, I'm not so much worried about. It's the anatomy. And when you have two light sources that are too close, they tend to create shadows that conflict in the face and increase the depth of, say, the nasolabial fold or the tear troughs. And I've seen this in quite a few pharmaceutical studies where, you know, you've got a patient in front of the audience. They've had this photograph taken with two-point lighting system, and they've made the face depth of shadows extreme. And then it's sort of a self-fulfilling prophecy. They'll say, well, this patient has really deep nasolabial folds or really deep tear troughs. We're going to put some filler in there. And the distortion that's come from a professional system is completely, you know, shifted the needle of where it should be. So that would be my main criticism of the IntelliStudio. I guess
Very
the other
good.
thing too, the other thing is it's a walled garden. They're a software, so they have proprietary file formats. And when we've had to decommission Canfield systems in the past, the issue is that, you know, they've got all these photographs which are your data but locked in their file format. We've gone for more of a, you know, open source method where we're using like industry standard JPEGs and raw images that the camera produces, and Microsoft OneDrive, which is all it's not proprietary platforms in any way. So if you need that file, you can grab that file very quickly, or if you need to share that file, you can share that file quickly. Sometimes these walled gardens, and this is true of RX Photo too, these walled gardens of data are hosted by the companies, or they're locked away in certain ways that makes it very hard to retrieve those files when you're simply trying to make a before and after or share with a patient.
That is, that rings true here. Like these walled gardens are, if there probably is one way to get to the United States, it's because they're starting to get irritated with all the walled gardens.
Correct. So
You
yeah,
did
that's
a
why
great job of explaining Canfield's proprietary file format, you know, and our clients are irritated with that and, you know, feeling held hostage, you know,
yes,
and how hard it is to even get pictures out, you know, like in Snap, you can only get one picture out at a time. You have to download each one at a time. And how
they
in
do
the
that on
heck are you
purpose.
going to upload all of, you're going to spend all day, click, 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 and
Yeah,
upload them to your website? At least in RX Photo, I'm not, you can batch download them. So
yeah,
at least a batch download, our system allows for a batch upload, you know,
yeah.
so you're not just sending all day, just click, 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 click. But you mentioned in some email prior to this something about the Victorian University study.
The Victoria University Dermal Sciences Lab, which is our sort of premier dermal school in Australia, and they've been a client for about a year, and I've been in orbit with them for a few years, you know, as I've been selling into dermatology clinics and into laser clinics. What I worked out by accident a long time ago is I would see these photographs in dermatology clinics taken under Wood's lamp, which is an ultraviolet light source that helps you see epidermal and dermal melanin in the skin, more epidermal melanin than dermal. What we worked out is, and it's a feature of our product, where you can take that original raw photograph, so you have that normal visible light image, and then you can apply skin filters to be able to see melanin in the epidermis. And I went one step further this year, like, let's measure this. And we measured it down to 2 millimeters into the dermis that we can see. What's happening there is as light bounces off the flash onto the skin, and from the skin to the camera, it's carrying some wavelengths of light, which we can interpret as the chromophores of the skin, and the camera can assign colors to that. So what's great about that is that you have someone, might be sun damaged, mid-30s. They know they've got a little bit of sun damage here, but when you apply this filter, it really highlights the degree of damage. So that would be for, say, photo damage or melasma. And what the University of what Victoria University said to me is like, okay, let's do a study with a cohort of patients and show just what we are seeing with your skin filters amongst these patients. But let's make it specific about hypertrophic scarring. I'm really passionate about scarring because in my alternate life, I do a lot of documentary filmmaking in developing worlds with different surgical charities. And I see a lot of burnt patients, a lot of really advanced hypertrophic scarring. So I'm always trying to think of how can we make how can we combine these two worlds of line that we can show clinical evidence of what's happening with the scar. So we're going to do a study showing document all these hypertrophic scars because you can actually show a little bit of the depth and the differentiation between the scar tissue, the background epidermis that's healthy, and the epidermis that's been lost to that contraction and that hypertrophic scar. So it's an exciting study, and it'll again sort of validate what these skin filters are doing that we sell in our system.
Wonderful. So we've got just a few minutes left. TK, do you want to do some rapid fire questions?
Sure. So our first rapid fire question is, what's the biggest mistake you see clinics making with their photography setup?
If they've got my setup, they're not making a mistake. No, I'm kidding. The biggest misconception is that they need a dedicated photo area. So that's usually the barrier of entry, where people say, we don't have a dedicated area. To which I say, when you have a system with lighting on the ceiling and no tripods and etc., you can be in any area. So you can share it with a treatment area, a reception area. So you don't need a lot of space. You need the width of a patient plus a bit of a buffer. So usually about 1.2 meters wide for faces and 1.5 meters wide for bodies. And then about 2 meters long. And then that's enough room to take photos.
Wonderful.
Awesome. I think you've already answered this one, but DSLR or smartphone, what's your choice for professional quality images?
Would say mirrorless. So mirrorless cameras are the evolution of DSLRs, which were, digital single light reflex, which had a mirror, which makes that big clap sound. Those are discontinued. We don't use them anymore. They've been superseded by mirrorless, which are smaller, lighter, faster, and cheaper.
That's
so
great.
definitely not a smartphone or an iPad.
It's great to know. So I was also reading a little bit about RAW files versus JPEGs, and legally, a JPEG can't be identified as an original image. I did not know that.
Correct.
Can you speak on that?
So a difference between a JPEG and a RAW file, which all cameras can produce both, is there's massive. So there's a technical difference in terms of detail. So the amount of detail a RAW file takes is order of magnitude higher than a JPEG. And that'll be detail in terms of your color fidelity, the gradients of, say, the skin tones, or the gradients of your skin tones, or the gradients of exposure values. But from a legal point of view, a RAW file has the ability to see its metadata and its history. And if you edit a RAW file, that's embedded in the file itself. So you can always go back through any open source software and see all the changes that have been made to that image. So that's why you can prove that a photograph has been manipulated or not, whereas a JPEG doesn't save that. RAW files are obviously larger files, but data storage is the cheapest thing in the whole equation at the moment. So you don't need to worry about the size of files anymore.
Well, Woodrow, it's been a pleasure and very um, helpful in knowing a little bit more on the state of photography in Australia and the United States, and this about the mirrorless camera, that's new to me, and the raw file versus the JPEG. I didn't know that. I love your passion, not just for the aesthetic industry, but for uh, burns and scars around the world and helping to document that. I can only hope that our relationship grows and that we continue to learn from each other and help our industry have higher standards in taking clinical before and after photos. TK, any last remarks?
No, I just want to say thank you. It's been incredibly insightful. We appreciate you waking up early to join us here in the US. And just if you want to leave any last words for our audience and where they might be able to find you.
Well, firstly, thank you very much for having me. It's really lovely to have a conversation with other people who are, in this battle to try, improve the industry and improve patients. Um, because, ultimately, life is short. We just all want to be honest and do the right thing by people. And I think photography has been that vehicle for me, and it sounds like it's that for you as well. Um, Shout out, I think I've got 4 or 5 clinics in North America, which they all know who I am, and I want to thank them for taking me on. They found me through webinars many years ago, so hopefully that'll grow and will make a bigger influence in the US. And to find me, the website is clinicalimaging.com.au, and the Instagram is clinicalimaging_systems. Funny enough, when I started this 10 years ago, when I saw no one had registered a company called Clinical Imaging, I got my credit card out really quickly to make sure that I got it that day. And I'm very lucky that I've still got that company name. So, although sometimes at conferences, people come up to us and it's like, so what do you do? And I look at the sign above us. I'm like, we sell carpets. So anyway, but it's all good fun. But no, thank you very much for your time, and look forward to collaborating further.
Great.
Awesome. Thank you,
We'll have
Woodrow.
all your contact information in the show notes below.